Welcome to the Motivational Midwife. My name is Lynn Jones, and today we are going to be looking at examining the baby after birth. So let's look at that immediate post-birth examination, and ideally you're doing this after the parents have had the golden hour, although in many instances the parents actually just want you to get on and weigh the baby so they know how much the baby weighs and that all is well, and then they'll do their skin to skin. So why are we doing it? Well, initially we're really doing it to make sure the baby has actually made a successful transition from intrauterine life. And we'll go into that in a little bit more depth in a different session, how the baby actually does that. We're doing it to highlight any abnormalities and then refer appropriately to the neonatologist to come and review the baby if you do highlight any abnormalities, and to give us some baseline measurements, so baseline weight, baseline head circumference. But remember, with your head circumference, there very often is moulding, so it's not always a true reflection of the baby's head circumference. So it is a top-to-toe, thorough, systematic examination of the baby. It's not the newborn infant physical examination, but it does need to be a thorough examination. So we can further break that examination down into three sections. So your general inspection of the baby, your more in-depth inspection of the baby, and then documenting your findings and discussing your findings with the parents. So let's look at a general inspection first. So I tend to do my examination either on the bed with the parents or in the cot next to the bed so the parents can actually see what I'm doing. So first of all, I'm looking at the tone of the baby. Does this baby appear to be well toned, or does it appear to be a little bit floppy? Some syndromes, particularly Down syndrome, often the tone can be really quite poor. Look at the behaviour of the baby. Is the baby behaving in a way you would expect a term baby or whatever gestation it is to be behaving? Is it, crying? Is it quiet? Is it vigorous in its behaviour? And the attitude, a term baby you would expect to have an attitude of flexion, so the arms and the legs will be flexed up. And also looking at its breathing, is it breathing normally? Does there appear to be any difficulty with its breathing pattern? And I will go into that in a little bit more depth with the in-depth inspection. So let's look first at the skin. And so we're looking to see, is the skin intact? Is there any areas that are broken? Is there any trauma obvious on this baby's skin? Because remember, skin is covering everywhere of the baby. So are there any areas of trauma? Is there any dryness, flakiness? If the baby is post dates, very often the skin can be dry, and then you can advise the parents accordingly, depending whatever national guidance is available at that time. So salmon patches are what are commonly referred to as stork bikes, and this first picture at the top here, you commonly find them on the nape of the neck. You find them above the eyes or above between the brows, and they are really just slightly dilated blood vessels, and they do tend to fade as the baby gets older, and often you'll find that they only really reappear when the baby gets really cross and is crying, and then they become more prominent, but they do tend to fade, and by about 2 years old they've usually gone. Hemangiomas are another name for the sort of nevuses or birthmarks. So your strawberry birthmarks is one of them. And this second one here is actually a strawberry birthmark, and you would document that as a strawberry nevus. If you weren't sure, then you would refer that to your neonatal team and ask them to come and review that baby. If there are any strawberry nevuses, particularly around the eyes, then it's very important that they are seen quite quickly so they can have a referral to an ophthalmologist, because there could be involvement with the eye. But we'll go into that in a little bit more detail when we do the newborn infant physical or NIPE session. And then you have hyperpigmented macules. So these are the sort of blue pigmentations that you often find across the sacral area in darker skinned babies. They are found on Caucasian babies as well, but they are much more common on darker skinned babies. And it's important that the position and the size, approximate size, are documented carefully, because these can look like bruises. So it's really important that they are highlighted to the parents, and also they are documented very carefully in documentation, not only your computerized documentation, but any documentation that is going home with the parents, so that this is passed on to health visitors and GPs. Are there any blisters? Babies do suck in utero, so sometimes they are born with blisters on their hands, or commonly on their wrists. Actually, you often see a little blister on their wrist where they've been sucking. Is there any rashes? Is the baby's colour appropriate for its ethnicity? You would expect a baby to be well perfused within sort of certainly centrally within sort of 60 seconds of birth. You're expecting that baby to be centrally well perfused. It takes a little bit longer for the peripheries to become more perfused. But does it look pale? Does it look unwell? And then we'll do the head in a little bit more depth. Apologies for my drawings. These are actually drawings I did when I was a student. So they are very, very old. So you're looking at the shape of the head, okay? Is there any abnormal moulding? So where the bones have overridden to facilitate birth. Is there abnormal moulding? Does the baby's head look a normal size for its gestation? Does it look particularly large or not? Are the fontanelles present? So you've got your posterior one and your anterior one. Do they feel appropriate size? Or do they feel very small or very large? I mean, you may not feel the posterior one at all if there's a lot of moulding there. Is there any caput? So caput is really a swelling on the baby's head. And this top drawing here, this green is the bone, and bone is covered by a layer of periosteum. And then this brown spiky bit is skin and hair. And really caput is a collection of serum between the periosteum and the skin. Okay, so the bone and the skin. And it can, because it's between the bone and the skin, it can cross suture lines, and it can be fairly well anywhere on the skull. Cephalhematoma, on the other hand, is a collection of blood, and it collects between the bone and the periosteum, so that covering that goes over the bone. And because of this, they will never cross the suture line. So you will never have a cephalhematoma that crosses the suture line. What you might have is a cephalhematoma with caput on top that crosses the suture line, and you're not really aware of the cephalhematoma until the caput has subsided. Caput is obviously present at birth. Cephalhematoma might be present at birth, but often comes up after birth, and it's usually because caused by friction, so it might have been a little bit of a tight squeeze for that baby to come through, so the head has rubbed against maybe maternal pelvis and caused those little blood vessels to rupture. Hematoma often gets bigger before it gets smaller, and so you need to inform the parents that actually it can take several weeks for this to subside, and it is normal for it to get bigger. Classically, you can see them sort of on the parietal bones, so they're sort of like Princess Leia lumps either side of the head. You may have one side, you may get both sides. Is there any evidence of trauma? So is there any breaks on the head? So in terms of, has there been a fetal scalp electrode? Because obviously if the skin is broken, that's a potential route in for infection and will need to be closely observed. Is there any trauma from the use of amnihook? Has she had her waters broken? Was it an instrumental delivery? So is there a chignon there? So that's where the scalp has been sucked into the ventouse cap. Is there any forceps marks on the baby's head or face? So, is there any obvious trauma? Then looking at the baby's face, does the baby's face look symmetrical? Does it look in proportion for its gestation? Do the ears look normally positioned? They don't look too low set, or are they fully formed? Do they have all their cartilage there? In a term baby, if you fold the ear over, it should flick back. That's called recoil. Preterm babies, it doesn't do that. Is the baby does the baby have eyelashes and eyes? Are they obvious? And this may sound very obvious, but does the baby actually have eyes? They don't always open their eyes straight away, and it is important to check that there are actually eyes behind the eyelids. Does the baby have two nostrils? Are they there? Do they seem to be flaring when the baby is breathing? So actually sort of flaring out, because that could be an indication that this baby is struggling to make that transition from intrauterine to extrauterine life. Does the baby have normal philtrum there? Can you see a nice bow-shaped lip? Is there any evidence of tongue tie or cleft palate? Can you see any evidence of that? Can you feel any evidence of that? Does the chin look normal? It's not receded or look particularly small. Likewise with the tongue, does it look large or small? When you then move down to the neck, it is important really to lift the chin up and really inspect in the neck area, because sometimes there can be sinuses, so little holes there that you could miss if you don't really lift the chin up and have a look. Is the baby able to move its head from side to side? Moving down, really have a feel along the clavicles, so there's no obvious signs of birth injury there. And birth injury doesn't just happen for babies who've had complicated deliveries. It can happen spontaneously. So just palpate along the clavicles. Do they feel intact? Do they, is it causing the baby any distress when you're doing this? Looking at the limbs, are they, I haven't got to limbs yet, have I? Looking at breathing, is both sides of the chest rising equally? Are the little muscles in between the ribs sucking in? That's called recession. And it could indicate that the baby is actually having difficulties making that transition. Is the abdomen look normal? Does it look very distended or puffed out? Is it soft to touch? Is the cord centrally situated? Is the clamp-on secure? It's not bleeding. And looking at the limbs, okay, is the baby moving all limbs equally? If you pop the limbs down the side, do they look equal in length? Are the joints working as you would expect? So can you bend the elbow joints and the wrist joints and the knees and the ankle joints? If you examine the digits, make sure that you actually separate each digit so that you don't miss any webbing or extra digits, or where the baby's digits may be curled over. And talipes, so this used to be known as club foot in the old days, so it's where the baby's feet either bend up or in or out. And it's important to document, even if it's just positional, because this could be a risk factor for hip dysplasia and require the baby to be referred for a hip scan when the NIPE examination is done. So looking at genitalia, so if we've got a little boy, is the penis situated where you would expect it? Is the urethra at the end where you would expect it? It's not above or below the penis, which is called hyperspadias and hypospadias, and may necessitate referral. Palpate both testes, and it's important to do that together, palpate them together, because it's very easy to think you've felt two when you've only felt the same one twice. With the little girls, have they got a labia minora and majora? Is there a clitoris? Is there a vaginal orifice there? Talk to the parents about vaginal discharge in little girls, that it is normal and it can be bloodstained. Talk to them about how to clean their baby, particularly little girls, from front to back. And then turn the baby over and palpate down the baby's spine. Also look at the back of the head and make sure there are no abnormalities there, but palpate down the spine. Does the spine feel straight? Does it feel curved? Does it feel twisted? Are there any gaps in it that you can feel? Is there a sacral dimple? If there is, can you see the base of the dimple? If not, you really should have a neonatologist come and review that and make sure we're not missing an occult spina bifida. Is the baby's anus normally situated? And you will only really know if it's patent once meconium's been passed. It's important to document if the baby has passed meconium and urine. And then finally, obviously, document all your findings in your trust notes. Make sure you've had that discussion with the parents of all your findings. Discuss with the parents if there is anything they are worried about already, because parents will know their baby very, very quickly, and they will scrutinize their baby and they will pick up things that you maybe have not picked up. And there you have it, examining the baby after birth. I hope you found that useful. If you haven't already subscribed to the channel, please do, and I look forward to seeing you next time.